while we hop on, would love for everyone to introduce themselves in the chat. If you could please put your name, pronouns, organization, title, role, and we didn't put it here, but I want to know what state you're in. So if you could add that, I know we got that in the registration information, but we often get questions just about like, is anyone else here from Florida? So please put what state you're in. And then what's bringing you to this meeting? What's on your mind? And since I'm talking, I'll tell you what's on my mind. I'm very distressed about the proposed change to the public charge rule. And I know Jillian's going to talk in a minute about some of Sheriff Strink's policy approaches around that and some potential language. But I'm going to go ahead and put the proposed rule change in the chat. And just really, I hope we can all comment because it's just feels really heartbreaking to see this proposed rule published. So I'm going to go ahead and put that there. So nice to see all of you, and we'll just keep letting people filter in for a minute or two more. Yay, Colorado! I'm also saying hello from Colorado, Denver.
Yes, hello, welcome to everybody. Just building off what Catherine was mentioning, I'm going to put a link in the chat to a statement from the Protecting Immigrant Families Coalition, of which Share Strength is a part. And in that statement, it's an initial response to the public charge rule that Catherine was alluding to. And in the coming days, Share Strength and other partners will be providing some suggested language to comment on the Federal Register open comment period, which I believe is open until December 19th. So please be on the lookout for that, as the public charge rule is something that could threaten the ability for a lot of people to feel comfortable participating in public benefits like SNAP and WIC. Not only for those directly affected by that proposed rule, but also for other people who might feel some rightful hesitation and fear around participating, even if it does not technically affect them. So anyways, please check out the statement that I put in the chat, and again, be on the lookout for an email from us about it and or an email from some of our partners.
Great to hear what's on everyone's minds. Thanks for sharing, Amanda, that you're thinking about how we can keep folks fed amongst HR1 cuts. And other folks would love to hear. Barbara, see that you're interested in nutrition, or nutrition healthcare provider interested in this topic. Who else? Did others? If you already introduced yourself, but you didn't share what's bringing you here or what's on your mind today, we'd love for you to add in the chat what you're thinking about or what you're hoping we'll talk about. Yeah. Sophie, we are always thinking about how do you center new perspectives in our work. So excited that that's what's on your mind today. Karen, wholeheartedly agree. Food security is the baseline for improving health.
Hi, Eliana. It's so nice to hear from you.
Kate Hansen,
Eliana is one of the origin story people for me. Sorry, Catherine, I spoke over
no,
you.
sorry. I got excited because I saw Kate Hansen. So Kate has been talking about some work around breastfeeding and access to things like pumps. And I am like hot to trot on this topic now. I saw that the recent report came out about access to breastfeeding related supplies. So anyways, Kate, I wanted you to know you've really inspired me. All right, we can move to the next slide. But for those of you who are just joining, please go ahead and introduce yourself in the chat. We encourage this meeting will be recorded and will be put on the network website. We encourage you to use the chat to communicate with one another, to ask questions of our panelists or of any of us. Please make sure you're muted. This is not a webinar format Zoom. This is actually a discussion. And so when you come off mute, we can all hear you. Next slide, please. So our goals today are first to increase awareness of new resources in the field available to support partnering with Medicaid to address food and nutrition security. Our focus in a lot of our conversation today is really around cost effectiveness. And so really excited to have a number of different perspectives of how we think about the cost effectiveness of food as medicine interventions. Our second objective is to articulate innovative strategies and inspirational case studies. So Kim, you're our inspiration. So excited to have you here. No pressure. And to foster collaboration and engagement. I always feel like 60% of the benefit of these meetings is the conversations you all have in the chat and the reminder that, oh man, I really wanted to reach out to that person. So really encourage you all to stay the whole time, because at the end of our meeting, we always have breakout rooms that are really solely for the purposes of connecting with one another and the speakers. And also, heavily use the chat or come off mute. We want to hear from you. Next slide, please. And I think I'm going to hand it to Julian here.
Yeah, thank you. So just to give a little bit of a foundation of what MFSN is, particularly if this is one of your first times with us, Medicaid Food Security Network is a national network of hunger, food security, food as medicine advocates who are working together to influence state Medicaid systems to adopt strategies that serve the needs of children and families enrolled in Medicaid, with an emphasis on food as medicine and closing the enrollment gaps in SNAP and WIC. We are co-convened by Health Begins, which is a consulting organization that works on upstream health-related social needs and improving the way that we deliver healthcare. Share Our Strength, as you may know, is a national nonprofit that is working to end childhood hunger, and you may also know us by the name of No Kid Hungry and the work that we do to increase access to school meals in all of their forms. And through this network, we are working together to create more glue between all of us. Infrastructure for collaboration. I saw at least one message in the chat saying, I owe you an email, which is exactly what we want to have through this space. Doing technical assistance, creating tools and resources for policy and advocacy so that we can all work with each other to improve the ability for the Medicaid system to address food security. One of the main tools that we always like to feature in our convenings is our policy dashboard. So if you scan that QR code, or if you go to the link that we'll put in the chat in a moment, this is our policy dashboard that shows examples of food security strategies in play in Medicaid systems at the state level, so that you can hopefully point to them and say, hey, why are they doing that over there? Can we do that here as well? And so just to preview the talks coming up ahead, we will hear from three really great speakers speaking about the intersections of SNAP, WIC, and food as medicine, and a couple resources that we in the MFSN team have been working on. So first we'll hear from Amanda Bank, representing Center for Healthcare Strategies. Then we'll hear from Kim Prendergast from C3 in Massachusetts. And then we will hear from Sarah Teppemer, who is an actuary working on a resource around FIM cost effectiveness analysis with us. And I will keep us moving forward just so that we can have more time with each other. So I'll hand it over to Amanda now.
Awesome. Thanks, Julian and Catherine. So grateful to be here. My name is Amanda Bank. I'm a program officer at the Center for Healthcare Strategies. And like Julian mentioned, I'll be providing an overview of a new brief that I co-authored alongside colleagues at Health Begins and Share Our Strength, titled Food as Medicine is Complementary with SNAP and WIC. Next slide. So as a quick overview of the Center for Healthcare Strategies, we're a nonprofit based in New Jersey, but we work with stakeholders nationally to strengthen the US healthcare system to ensure better and more equitable outcomes for those served by the Medicaid program. And while we do a lot of different types of work across Medicaid stakeholders, I spend most of my time working at the intersection of Medicaid and food and nutrition insecurity and coordinating across state and federal food support programs. And so the work that I get to do at CHCS is so well aligned with the Medicaid Food Security Network's mission and goals, and I'm thrilled that we were able to co-author this brief with them. Next slide. So as a quick summary of the problem and why we wrote this brief, diet-related illness accounts for $1.1 trillion per year in healthcare costs. And food as medicine, which is the provision of healthy food resources to prevent, manage, or treat specific clinical conditions in coordination with the healthcare sector, has the potential to contribute billions of dollars in healthcare savings as well as improve health outcomes. However, while food as medicine is a necessary component to treating and managing certain health conditions, it's only one of several important ways that we can support Medicaid enrollees' whole person and whole family care needs. And so our brief really aims to outline how food as medicine is complementary to federal food support programs like SNAP and WIC, and explore how these programs can and should work alongside each other to build a more comprehensive and efficient nutrition support system for children and families. So if you'd like to dive into the brief more fully after hearing the presentation, on that last slide, there was a picture of the QR code, which will take you right to the brief. But we can also drop that in the chat. You can go to the next slide. So in the brief, we dig into the following key messages. First, we write about how Medicaid-funded food as medicine programs are complementary rather than duplicative to SNAP and WIC, both programmatically and legally. And so in this presentation and also in the brief, I'll share more specifically about what this means, as well as some state examples of how to ensure non-duplication. Next, we write about how Medicaid-funded food as medicine programs work together with SNAP and WIC to expand healthy food access as part of whole person and whole family care to prevent and treat diet-related diseases. And so again, I will dive deeper into this in the presentation, but at a high level, food as medicine services are generally more intensive and time-limited, and they work better when integrated with SNAP and WIC to really foster longer-term continuity of nutrition care. And then finally, we write about how we're really facing a critical moment amid funding cuts to SNAP and Medicaid, which are reducing the availability of nutrition education and access to healthy food. And so coordinating across food as medicine, SNAP, and WIC is more critical now than ever before, and just makes logical sense to ensure that we keep folks fed and healthy. Next slide. So, as is true with any good food is medicine presentation, you have to have a slide with the food is medicine pyramid. So here it is. But jokes aside, the pyramid really is a useful visual in showing how direct food as medicine interventions at the top of the pyramid, like medically tailored meals, medically tailored groceries, and produce prescriptions, are distinct from, but complementary to, those more preventative federal nutrition programs at the bottom of the pyramid, like SNAP, WIC, and school meals. And it's also important to note that interventions at all levels of the pyramid are linked to improved health outcomes and reduced healthcare costs. So we need all of these levels of the pyramid to exist and be coordinated to maximize the potential health impacts and cost savings of these services. Next slide. So now that we've established how these services are distinct programmatically, how can we ensure non-duplication legally? Well, first we need to ensure separate funding. So on this slide, I outline how each of these services are funded. So first, food as medicine can be funded via philanthropy and government grants, like the GusNIP program, through Medicaid and Medicare pathways like 1115 waivers in lieu of services and HCBS waivers on the Medicaid side, as well as supplemental benefits through Medicare Advantage on the Medicare side, as well as optional managed care benefits like value-added services or community reinvestment requirements. On the other hand, SNAP and WIC are funded via the USDA through the Farm Bill. So there's also both federal and state guidance that requires Medicaid-funded food as medicine programs to be non-duplicative with existing food assistance programs. And the most recent guidance was included in the 2024 HRSN framework that was issued during the Biden administration, which stated explicitly that Medicaid-covered services and supports to address HRSN will not supplant the work or funding of another federal or state non-Medicaid agency and must be complementary to existing social services such as SNAP. So while this guidance was rescinded in March of 2025, CMS has not issued replacement guidance, and the principle remains relevant for states to follow. Next slide. So here I just outline how 3 states are following that non-duplication guidance in their 1115 waiver and in lieu of services program design to ensure that implementers coordinate SNAP and WIC with Medicaid-funded food as medicine programs. So in Massachusetts' 1115 waiver policy guidance, it includes language that Medicaid food as medicine interventions must include SNAP and WIC navigation assistance and connect and refer enrollees to appropriate supports. And I know that we're hearing from Kim Prendergast next, who will really dive deep into how this policy guidance looks in practice in Massachusetts. Next, Michigan's in lieu of services guidance notes that enrollees receiving SNAP and WIC are explicitly eligible for food as medicine and expects the Medicaid health plans to assist applicants who are eligible for SNAP and WIC but not yet enrolled. And then North Carolina's 1115 waiver policy guidance also includes language on how Medicaid care managers should screen for and help enroll individuals in SNAP and WIC, and then determine if food as medicine can complement SNAP and WIC services to really avoid that duplication. Next slide. So this is a screenshot of North Carolina's 1115 waiver policy guidance, walking us through how a case manager can support a Medicaid enrollee through the process of navigating non-duplication of federal food support programs and food as medicine services. So Roger is a Medicaid enrollee who's experiencing food insecurity and needs assistance affording nutritious food. A care manager would help determine that Roger is indeed eligible for SNAP and help enroll Roger in SNAP. And then while Roger's application for SNAP is in progress, the care manager can also refer Roger to the Medicaid-funded Healthy Food Box program. And then after that time-limited Healthy Food Box program is up, the care manager would check in again with Roger. And if the care manager determines that SNAP is still not enough to meet Roger's needs, the care manager could continue to refer Roger to receive healthy food boxes, or if the care manager determines that Roger's food needs are met, then SNAP would continue and the healthy food boxes would fall away. And so I know that North Carolina's Healthy Opportunities Pilot Program services are not currently being funded, but the general workflow that's outlined here of how a case manager can help ensure non-duplication across these services remains relevant and hopefully helpful for other states to follow. Next slide. So shifting gears, now that we've established that these services are indeed complementary, I want to talk about how all of these services can work together to more comprehensively support families. So SNAP and WIC are supplemental by design and are not intended to meet the full nutritional needs of individuals and families. And then, like I mentioned, direct food as medicine programs are usually intensive and time limited. So the combination of food as medicine, SNAP, and WIC, and nutrition education, which I haven't talked much about yet, is really the secret sauce for creating the conditions for long-term healthy eating. And nutrition education can be used to guide participants on how to use their SNAP and WIC benefits on healthier food. It can be used to support with skill building and really support that longer term behavior change. I just wanted to note that if anybody was thinking there might be potential for duplication with nutrition education, HR 1 cut SNAP Ed, which was the SNAP funded nutrition education program. So while unfortunate, now the responsibility for nutrition education falls on healthcare funded programs predominantly. Next slide. So now I won't dig into this fully, but I wanted to note that in the brief, there is an extremely illustrative case study of the way in which a family can use SNAP, WIC, and food as medicine services in a coordinated way to support them in gaining long-term nutrition, health, and economic empowerment. So if anybody's looking for a really concrete example of how all these services can complement each other to support that whole person and whole family care, to just take a closer look at that case study. Next slide. So I'll wrap up my portion of the presentation by just walking through some concrete opportunities that we identified in the brief around ways that we can better coordinate these programs. So at the healthcare level, we could consider establishing healthcare-driven SNAP and WIC navigation assistance as a standard of care management alongside those more tailored Medicaid-funded food as medicine services. At the state level, state Medicaid agencies could strengthen food as medicine service delivery by embedding clear requirements into managed care or healthcare provider contracts for SNAP and WIC navigation assistance, as well as provide guidance and support around data sharing infrastructure and evaluation across these programs. And then at the federal level, CMS could provide updated guidance on the complementarity between healthcare-funded food as medicine and existing USDA programs like SNAP and WIC to replace that rescinded guidance. And also that guidance could provide more clarity around braided and blended funding between Medicaid and USDA funding as a way to maximize funding sources and sustainably provide more person-centered care. Also, Make America Healthy Again Commission's recommendations to increase access to healthy foods through government-funded programs might also present a future opportunity for states to fund food as medicine. So that wraps my portion of the presentation. I'm happy to answer any questions in the chat or in the breakout room. But if you go to the next slide, there's just a quick plug for CHCS and the resources that we are putting out all the time on our website and on LinkedIn. So just grateful for the time today and excited to hear from the other presenters. I will pass things off to Kim.
Before Kim starts, just folks in the chat, we always love your feedback. Like, did this help you? Did you use it? Did it meet the mark? Did we miss something? Did you disagree with us? We love all the feedback. Any feedback you have time or willingness to give, welcome it in the chat or email us or I don't know, let us know, but would love to hear if this was at all a useful resource for you. And also welcome your questions.
Totally. Thanks, Catherine.
There is a question in the chat. This is a tough one. So North Carolina was a 5-year pilot program. Whose funding was not renewed this year. What would be the strategy recommendation to ensure embedding these programs together don't end when just starting? So welcome anyone in our group to respond, but also I would love to hear from everyone on this call. You all are experts. How can we keep these things going and, you know, make them more resistant to the fluctuations in funding that, you know, always come, but we know are inevitable at the present moment? Yeah, Sam, would love to pick on you and see if you have any thoughts, but also anyone on the call. I think our hope or my hope is that some of this cost effectiveness conversation helps make that argument that doing this is a cheaper alternative to things we've already committed to pay for and that we're unlikely to cut. But welcome anyone else's thoughts and encourage others to pipe up. And Sam, I saw you come on video, so hopefully.
Yeah,
Hi.
happy to just say hi really quick. I think North Carolina is a red state, so I think bearing that in mind. But I think the main thing about it not getting funded is that these waivers do require state appropriations. And so it's important to understand that from the beginning and get buy-in from the beginning. I think North Carolina didn't, it's like weird to talk about, but it's like there wasn't exactly buy-in from the beginning. There was a lot of just like political horse trading happening, right? And so I think when it came due for renewal, the department applied to CMS, got approval from CMS, and really hoped that having some research recently published saying that this saved money was going to be enough. And I think from a state legislature perspective, they were not looking at long term. If we invest 10 million, we'll save X million. And it's not 10 million, it's 81 million that they were asking for. They were looking at today we can give you $0 or we can give you multi-million dollars. And I agree that it's a short-sighted approach, but that's really what they were looking at, is that they were like, we can give you nothing, and that's an option. And that's what they did. So I think the ways that we've been talking through protecting this is looking at an in lieu of service model instead of the waiver model, especially in a red state, because it doesn't require state appropriations. And like I said, I think buy-in from the beginning from red legislators would be helpful. And I think the other piece is ensuring that CBOs, while the waiver is running, are gaining the capacity to be, I was just talking about this earlier, to be integrated into healthcare if that's what they want. So if a CBO could have taken those 5 years to become HIPAA compliant, maybe have a high trust certification, develop capacity around 837 claims, and in principle, even though this funding has stopped, they would have access to additional contracts, either directly with Medicaid or with other providers, other payers. So I think those are like the 3 things I would say for that one.
Thank you so much, Sam. I appreciate us putting you on the spot.
This is Maria.
Maria
I would
here,
just
yeah,
add to what Sam, I would just add to
Sorry.
what Sam is saying a little bit, because I think there's also like, completely agree with like there was miscellaneous politicking that had nothing to do with this program. And I think there are other like smaller things that become dominoes. So for states that are looking at this at the agency level, I would just advise like there are small communications things that like come back to haunt you, such as we named our entire initiative, like our pilot, after our entire initiative, which makes it really challenging when the name itself becomes what people are hanging on to and saying, well, we, the legislature, have now backed ourselves into a corner where we're doggedly saying we're not funding HOP, but we agree that it's great and it's a great program and it's really cost effective, but now we are doggedly saying we are not going to fund this. And it's more challenging to give them an out because we have now named our pilot after the initiative within which it lived. And that's like such a small comms thing that we probably didn't, I wasn't here at the time, but also we probably didn't even think about it way back when we were naming this. But like, just strategic, tactical things to bear in mind. And also there are pieces of like, I think one really smart thing I saw in Western North Carolina was over the years, there was a network lead there that really from day one began building, built themselves into this existing coalition. But I think they also, like similarly for other states that are building up these CBOs, of like creating a coalition that included state legislatures from across the political spectrum and really trying to speak to them in terms of like, these are your constituents and these are the programs and these are the health access concerns that affect them. And here's this thing, which in this case was HOP, and here's what it is, and like really demystifying it from an acronym into just what it means for the economy of their population. And for all that HOP is not currently funded, we are now at a place where there continues to be this divide between our state Senate and our House on support for it. And a lot of where we see that is where there was that longer term investment in building these relationships is where we're seeing like senators and particularly saying like, yeah, we get what this is. We think it should be funded. And then in the House, they were playing catch up, and is more of where we're seeing some of that tension of like, well, we already said we weren't funding this. So how do we not fund this, but also still find a way to be able to support this type of work? And then I agree with Sam. I will just push a little bit on Medicaid agencies to just acknowledge like there is a cost. And so this is one of the challenges we're working through. And I would love to talk to other Medicaid agencies about this, of like, even like the fact that within ILOS, you still have to build that into like build actuarial models, be able to price it out. And there like becomes a tension that we're working through in North Carolina of like, how much flexibility do you maintain versus how much do you standardize? Because we are going from a model that was, by all accounts, very like, I think there are entities within North Carolina that would say this could have been even more standardized, but from a policy perspective, this was a very standardized, rigid program and how it was stood up. And so we're going from that model into ILOS, which is very fluid and very much at the discretion of health plans. And so that is a particular tension that I would love to be able to talk to other states about how they're navigating it. Yeah, so that's I'm wondering if there are others from North Carolina, if we just keep adding on, but that's, I think, just another North Carolina perspective.
Yeah, Gary.
It's so interesting hearing you talk about that, Maria, because in Massachusetts, we struggled with the sort of opposite, where our pilot program was a little bit more thousand flowers blooming, and then we had to condense it and to standardize it really to fit into the managed care environment. So it is not in the in lieu of service sort of framework. So I think it is just interesting hearing about the different perspectives. A couple of other thoughts that come to mind around how to get this to become a little bit more sustainable. And sorry that the lighting is so bad here. But I think one other way to potentially try to have there being a little bit more staying power, and who knows if this happened or didn't happen in North Carolina or anywhere else, is trying to really connect with the farming sort of community and to make this about a local economy kind of discussion. So some of the things that we have heard from our HRSN nutrition providers, who are actually the ones who are producing the food, not just getting it from other places, is that this is a new book of business for them that actually is more sustainable and more reliable than, for example, existing community supported agriculture shares. Because for healthcare, it's not seasonal, right? Like if you're prescribed a food box, it's not like you only need it from like April to November. You need it throughout the entire year. And so what that means is that farms, they can start to rely on this and actually do season extensions so that they can build greenhouses, that they can actually grow food during the winter, as opposed to just having it be the more traditional growing season when the weather permits, right? And having this be a local economy kind of boost or shot, could potentially help with helping to cross the aisle in states where maybe the agriculture sort of industry may be really prominent. So just some other thoughts.
Oh, I love all these thoughts. They're so incredible. And we, I think you've queued up some of the conversation we're gonna have lately in the next few minutes, but also so excited to have so many incredible people here. There's so many experts in our attendees. But I'm gonna pass it to Kim.
Great, thank you so much. I'm Kim Prendergast, Vice President for Community Care Cooperative. And I was asked to come and join and talk about sort of the provider ACO approach to thinking about food as medicine work and SNAP and WIC. So we can go to the next slide. I want to start by just saying a big shout out to my friend Gary Singh, who's in the Witness Protection Program, I think, but who leads the work around the Health Related Social Needs Program here at Mass Health here in Massachusetts, and Jessica Bowman and Allison Rich, also from Mass Health, who are on the line, who have just done such amazing work, really visionary supports to to getting this program off the ground that we've been running for the last couple of years. So we can go to the next slide, Julian. So Community Care Cooperative, C3 is my organization. We are one of 17 accountable care organizations in Massachusetts. My organization specifically works with federally qualified health centers with the goal of improving the health and wellness of people we serve. So we're thinking about primary care and ways to improve financial performance and advancing racial justice broadly. And we're, as an accountable care organization, we bring together health centers to think about cost and quality of care in a couple different lines of business. We are a Mass Health primary care ACO. We have about 190,000 members across 25 health centers and provider practices in Massachusetts. And then we also have several Medicare ACOs in Massachusetts and other states. We do a lot of ACO performance and support, shared services, and then we have a technology subsidiary that deals with Epic, and we have a pharmacy subsidiary as well. So the work that I'm going to talk about today is all related to our Mass Health primary care ACO and the flexible services and HRSN services programs in Massachusetts. So for the next slide, I feel so blessed to work in an organization that really cares about social health as part of the way that we think about primary care and physical health and behavioral health and social health being so integrated. I joined the organization about 6.5 years ago when the Flexible Services Program funded and authorized through a Section 1115 waiver in Massachusetts was just starting. And when I interviewed with the CEO, she said, no one needs to convince us here at Community Care Cooperative that this is important. We just want to hire somebody to implement the program and really do it well. So it was a really exciting opportunity to come and build out our social health strategy and do the and stand up this work. So we think about social health as screening for health-related social needs, which is part of the contractual requirements that we have as an ACO in Mass Health, and also just such an important way that we understand the needs of our patients. And then we think about all of the ways in which we connect members to existing community resources, connecting to SNAP and connecting to WIC and community local food resources, thinking of all of the care coordination activities that need to happen to support our members, and then the ways in which we invest in care coordination partnerships and new programs to extend what exists today. And so this is in particular thinking about our 1115 waiver funded programs. The next slide, just to talk for a sec about the health-related social needs screening domains. Today, we're talking about food insecurity and the food as medicine programs, but we are screening our members for a host of domains to talk about all of the needs that they may have. And so our Medicaid patients get asked questions about food insecurity. We use the hunger vital sign 2 questions there. We're talking about housing stability and housing quality. We're talking about utilities, transportation, and digital access. So our community health workers and others, when these screenings are taking place, we're thinking about a family's needs really broadly and trying to assure that we're connecting our patients with all kinds of resources that are important to support their health and to support their economic well-being. Next slide, please. So very specifically thinking about the ways that our ACO is coordinating SNAP and WIC and food as medicine supports. In this round of our 1115 waiver, the primary care work that we do is funded through a primary care capitated model, which means that our health centers are getting paid to care for members really in a really holistic way. And one of the requirements that we have is to assure that care coordination is happening. So for members in primary care at the health centers, the care team includes a community health worker who, as part of care delivery really broadly, is conducting that health-related social needs screening, providing care coordination to support members with a SNAP application, with WIC if that's appropriate for mom, the maternity population and parents with young children, and then making referrals to other community resources. And community health workers are also identifying eligible members for other food as medicine programs, in particular our health-related social needs program, and making those referrals. So very standard in the way that we deliver primary care, we're thinking about all of these aspects of social health, starting with SNAP and WIC before other services are being offered. And I feel like Mass Health has really taken all of Amanda and the Center for Healthcare Strategies advice already in building that in and saying this is contractual requirement. This is how we provide care to Medicaid patients in Massachusetts. Same is true with our care management programs. So as an accountable care organization, we have care management programs to support members with complex health needs with additional nursing, social worker, community health worker, provider supports to help as they're transitioning from hospitalizations, a transition of care program, supporting patients through complex care management in an outpatient situation, maybe when patients have multiple new diagnoses, lots of medications, experiencing more adverse outcomes than normal, or patients in a high-risk maternity situation. Again, those care teams include a community health worker who's conducting a health-related social needs screening at the beginning of that engagement and assuring that members are enrolled in SNAP and WIC as appropriate. And then again, their staff are also referring the eligible members to our food as medicine programs. And then as an accountable care organization, we have a team of member advocates, and you can just go back one slide real quick, Jillian. We have a team of member advocates who are taking inbound calls from our members. They field hundreds of calls every month, and they're hearing from members about what they're concerned about. They'll call with food concerns. They'll call when they're having issues with a landlord sometimes. And so they are very well versed in helping members know, routing them to apply for SNAP and WIC, using Find Help to be able to identify other resources, as well as getting them into our HRS and services program. So in the next slide, I'll tell you a little bit more about our HRS and services program. This is the Massachusetts program that was built on our first successful flexible services program, providing targeted support for our Medicaid members with complex health and social needs. So in 2018, the beginning of our 1115 waiver, the last waiver, the team received authorization to be able to start flexible services. That program actually kicked off in 2020. Right at the beginning of the pandemic, which gave us all kinds of challenges. But that program gave us the ability to test some new and innovative models, as Gary mentioned. And then at the beginning of this year in 2025, we have the evolution from flexible services to the health-related social needs, or HRSN services program, which has moved into a managed care framework, which means that our community-based organizations are now HRSN providers who are known to the Medicaid agency. And we're actually billing claims and sort of running through the very typical medical process for all of these services. I will say we're not spending a lot of time on this, but I saw some references to hubs in the chat earlier. So Communicare Cooperative, my organization, we act as a hub to be able to bill claims and provide a lot of support to our HRSN providers or community-based partners on their behalf to assure that those partners are able to participate fully in the program. So happy to talk about that offline as well. All right, so next slide. So that's a little bit of an overview of the program. All accountable care organizations need to offer at least one type of nutrition service, also housing services, but we'll just talk about nutrition today. So every ACO picks at least one to provide as a covered supplemental service subject to the budget availability under this program. There are nutritionally appropriate, and then there are medically tailored services. So we have, at C3, we have selected all three of the medically tailored services as the options that we offer to our members. And so we offer medically tailored meals, medically tailored grocery boxes, and medically tailored food vouchers to our members, with the first two of those being home delivered for all of our members, and the medically tailored food vouchers are those that can be used to purchase groceries and produce at various places. Nutrition education and kitchen supplies are available to members receiving any of those supports to be able to support them in using the meals, the grocery boxes, the food vouchers to meet their nutrition and food security needs as well. Next slide. So these are some of our partners. Just wanted to call out all of the folks that we work with. As a statewide accountable care organization, we have health centers all over the state and really want to be sure that we are investing these dollars in the local economy and working with the organizations that are so experienced at supporting individuals in their communities. So we work with food banks, we work with Project Bread. I saw Courtney on the call, so thank you very much to Courtney, who's one of the dietitians that does great work with our members. So a variety of organizations that you're probably familiar with. And I really like that Gary called out some of the local agriculture organizations. Sustainable Cape is a small community supported agriculture, local farm organization on Cape Cod in Massachusetts. And we're delighted that we're able to keep them in this mix because as a hub, we can provide a lot of the technical assistance that they wouldn't be able to do if they were working on their own. I also just want to say a big thanks to our friends at IQPay and at DoorDash, who are, I think, also here, who they're not our contracted partners, but do a lot of work to make all this possible. Next slide. So I wanted to walk you through kind of a member journey, the referral process, and how we're thinking about SNAP and WIC and the Food as Medicine programs within HRSN services. So as I mentioned, both in primary care and care management, the community health workers that were other members of the care team would meet with patients virtually in person or in person to conduct the HRSN screening and talk with members about their social needs. And at that point, we would be discussing if members are enrolled in SNAP, if that's appropriate, if they understand how to update their information, if that's necessary. Also talking about WIC, if that's appropriate for their situation. That's going to happen before a member is referred to the HRSN services program. So we'll help to do that application or sometimes refer to Project Bread and their food source hotline if that makes more sense for the member. And then again, if a member is eligible for the HRSN services program, the community health worker will make that referral, send it to C3 to our central team, who will then confirm all of that information before we review and triage and refer that member to our appropriate community-based organization partner. So for example, if we send that member to Project Bread for medically tailored food vouchers, they're going to get a call from the dietitian and they're going to work with the nutrition coordinator who's assigned to that member to talk about starting food as medicine services, but also discuss the other kinds of supports that the member might be eligible for, and just confirm that they're receiving SNAP, that they understand how to utilize their SNAP benefits in coordination with other supports that they're receiving. And then again, at the end of the team, we're going to stay closely connected, the community health worker at the health center, our team at C3, and our community, our HRSN services partners. And when a member is sort of ends the program and stops receiving HRSN services, one of the things that we do is make sure that they have a sense of how do they access resources moving forward. So if they become ineligible, we'll also, again, talk about SNAP with other services to assure that they continue to receive those benefits also. All right, next slide. All right, just to bring it back to the food as medicine pyramid, because we need to do that, but wanted to just kind of think about, show you visually the way that we're thinking about this. So really the bottom of the pyramid and all of the government nutrition security programs, we're thinking for all of our members that we should be assuring that anyone who's eligible is receiving those services, and that members who meet the eligibility criteria for HRSN services and experiencing food insecurity are accessing those food as medicine programs at the top, all with nutrition education and counseling sorted, added in to be sure that we're supporting patients as fully as possible. Additionally, we're thinking about lots of other supports for our health center staff. So we're as we're supporting health centers in implementing health-related social needs screening, we're sharing their data with them on a regular basis and talking about what's easy and what's difficult about that. And we do a lot of training. Every month we have a webinar training, part of our SDOH training series, Social Drivers of Health training series, with many of those trainings focusing on the way that we conduct screening, thinking about trauma-informed care approaches to this kind of screening, and then also talking about what's changing with SNAP and WIC, and just assuring that the staff working with patients know how to make appropriate referrals, have all the right tools at their fingertips. And then we spend a lot of time working with the Find Help platform. We have a C3 specific version of that to be able to support our care teams, our staff, our member advocates, and routing patients to the right places. So I think that is it for me. I just want to say one final shout out to Crystal Adams on the team. We have a program evaluation manager at C3, really doing a lot of work around data collection to help share as much of this as we can. And one final note, we did just publish in Massachusetts, Gary and the Mass Health team and others published evaluation of the first 5 years of flexible services and did show some ROI on that. So as we turn it to Sarah to talk about cost effectiveness, maybe we could put that Health Affairs Journal in the chat as well. So turn it to you, Sarah.
Great, thanks. And Catherine, anything you want to say in between?
No, I just want to, Kim, you have some questions in the chat, so hope you can hop into the chat and weigh in a little bit.
Absolutely. I'll answer in the chat and then look forward to talking with some of you in the breakout as well.
Great. Well, and Catherine, do I have until 30 past the hour, or should I go? Can I go over?
You can go over.
You can, yeah.
Okay. Okay, cool. Just wanted to make sure.
Wait, I do want to
so-
say one thing. You have to pay attention to what Sarah's about to say because we're going to be crowdsourcing data from
Yes.
you all. So you need the foundation because then we're turning to all of you to give us insights because the literature is lacking in some areas. So for those of you who are multitasking, now's the moment to pay attention.
Thanks, Catherine. Yeah, so thanks. It's really great to be here. Thank you for letting me share. And Kim and Amanda, thanks for letting me share the platform with you. We are working on a paper that will get into sort of the methodologies behind cost estimates. It's focused on, I should have a pyramid slide, but I don't. So it's focused on the second and third from the top tiers of the pyramid. Because medically tailored meals, there's quite a bit of literature. The next couple down, less so. But we also recognize the need of integration between SNAP and WIC. So we'll talk about that in a few minutes. But really, the cost estimates are, I think, becoming more and more important. And states are looking at those and they want to see, they're evaluating those. And so if they're not done with rigor and really a solid estimate of cost, your program may be rejected. And at the same time, if you aren't taking up the opportunity to think of some of the offsets that might offset the costs, those are also things we want to be talking about. And so we are, like I said, we're working on this paper. We're going to be crowdsourcing some assumptions that are going to go into our modeling that we're using in the paper. So stay tuned. We'll be having those in a second. But before we do, go ahead, next slide, Julian. Just talking about a couple things, and Amanda touched on these as well, but there are several policy levers to address the food insecurity needs. And a few of these are more at the state level, and then others are more at the MCO level, but some of the levers are MCO care coordination requirements. And we've noted here when they're included in the capitation rates, and also how are they treated in the MLR, because that can be important to the MCOs and the payers. So care coordination requirements. The second is ILOS, or in lieu of services. I'll try to outline the acronyms. I saw the one thing in the chat. MCO, by the way, is Managed Care Organization. Hopefully everyone knows what that is. There's also directed payment programs, value-based payment requirements, performance improvement plans. Now we're getting into the more of the MCO type levers, community reinvestment of MCO profits, and then finally value-added benefits. And I won't dig into these here because just in the interest of time, we want to get through some of the other stuff, but just wanted to note these, and they're in the slides. And the slides will be sent out, right? That's the plan, and people will have access to this later. Okay, good, I got a nod. Okay, go ahead, Julian, to the next slide. And here we're talking about, so if you're going to do a fiscal analysis or a cost analysis, there are a couple ways that might originate. And here, this is just a summary of how you might want to engage your program or your entity to make sure that you're allowing enough time and engaging the right folks. So sometimes the first row there, sometimes it's initiated in the legislature, and you want to make sure you're engaging with those legislators, and the fiscal note entity and or the Medicaid agency who will be providing input for the fiscal impact. So making sure you're just engaging with those folks as early as possible, but providing that data kind of all the way through, and not just at the end or not just at the beginning, but making sure you're following us on. The second area where this might originate is with the Medicaid agency itself, and it's in the Medicaid budget. And so you want to make sure you're engaging with that Medicaid agency staff and whoever's leading the budget process in that strategy. You might want to make sure you understand your state budget setting timeline and appropriately engage at that time, probably 6 months prior to when the legislative review of the budget happens, at least. And then the third area would be when the Medicaid agency is setting their MCO rates, and especially when you're talking about an in lieu of service and ILOS, the Medicaid agency staff will be working with their actuary to calculate those capitation rates. And in many cases, and we'll talk about this, those cap rates are going to need to include the ILOS calculation. And so you want to make sure that the actuary is aware of your program. And actuaries are typically doing those capitation rates somewhere, well, it can vary a lot, but somewhere 3 to 6 months before the actual fiscal year starts. So you want to make sure you are understanding that process, the timing, and then making sure you're engaging with the Medicaid agency at that time. Let's go ahead to the next slide. Okay, so fundamentally, there are a few things that we want to think about when we're putting together a cost estimate, and they're just sort of building blocks that should be considered. When we're talking about the cost, and this may seem kind of simple, but it's really helpful to break it down this way so that when you're setting assumptions or when you're trying to do your cost estimations, you're thinking through all of these various pieces. The first thing is, on the left-hand side, is the actual cost of the intervention itself, the actual cost of the food program or the food. And that really breaks down into unit costs, like actually the fixed cost of the food, the materials, the boxes, anything else that actually goes into that unit that the person will be receiving. And then the second thing is any additional costs. And there can be lots of additional costs, but those could include like the delivery of the food, dietitian assessments, any other care coordination services that would go with that food program, and assessments of eligibility might also factor into that. But those are things you want to make sure you're thinking through all of the various pieces. And then that, of course, that unit cost will get multiplied by the number of member months. And as an actuary, I think member months. And really what that means is the number of months that a member is eligible for a service. And because capitation rates are on a monthly basis, everything happens in member months. And so it helps to put everything sort of on that apples to apples basis, especially when you're going to be integrating this with cap rates. So in terms of member months, you want to think about, of course, that total eligible population and the average number of member months of that whole population that might be eligible for your services. And that is where you start. But then you got to think about that's probably not going to be the total population that is going to be served by the benefit. That population, we need to reduce that for, number one, the portion of the population that we can't successfully outreach to. So we might try to outreach, but we can't reach them. That can be a portion of the population. And think about that, because we're going to be asking you about it in a couple minutes. Second is who declines to participate, because not everyone will want to participate. And just that's another, what we call a decrement. And then finally, there's a ramp up time in terms of how long it takes. Maybe it's staffing, maybe it's other reasons, but how long does it take to actually ramp that to that full number eligibility population? Because not everyone is going to be eligible or join the first day of the program. So you have to think about how long it's going to take, because if you don't consider those, you're going to overestimate your population, you're going to overestimate your cost, and potentially run the risk of a program not being approved because the cost is high. And I think the other thing to add here is when we talk about who declines to participate, that could also mean people who've started the program but dropped off. So we want to also think about that when we're building these assumptions. Finally, at the bottom of the slide, we talk about this, but we want to see how the cost of the program that we've just calculated, how does that compare to the total capitation of the population's managed care program? And managed care program has a distinct meaning, and we can talk about that later. But really, so for example, you might have a capitation program or capitation rate that covers the whole TANF population, for example, but maybe we're offering the service just to the pregnant population. And so we would still take that pregnant population cost over the whole capitation, meaning that the overall cost would be relatively smaller, which is good because you want to make sure, number one, you have to stay below 5% of that total capitation for all ILOS for all ILS benefits. And then if you're over 1.5% of that total capitation, there's going to be additional documentation required. And we will probably not cover that today, but we will cover it in the paper that we're going to be releasing hopefully next month. Let's go to the next slide, Julian. Okay, so in addition to costs, we want to make sure that we're thinking about offsets to cost. A lot of these programs have a lot of evidence saying that they do reduce medical costs in the longer term, or even in the short term. And as we heard from Amanda earlier, it's really important that we think about how this integrates with SNAP and WIC. And when you are implementing a food as medicine program, there's a great opportunity to get folks enrolled in SNAP and WIC if they weren't already. So the first step is to get them enrolled and make sure that we're closing that gap. And then when we do close that gap, we know there's very, very strong evidence about SNAP and WIC programs and downstream medical savings. So the first step is just to make sure you're optimizing whoever should be in SNAP and WIC and getting them enrolled. And then we want to layer on top of that the savings that might have resulted from our intervention that we're talking about. And a lot of the evidence talks about specific utilization metrics such as ER visits or hospitalizations or pharmacy spend or preterm birth rates or other things. So those are things that should be factored into your calculations, especially when there's an evidential base for it and that you can defend it. And we'll talk about that in the modeling that we've built for the paper that's coming out next month. But the bottom line is the savings amount should offset the cost calculations to the extent that it's evidence-based and it's defensible. Let's go ahead to the next slide. Okay, so here we go. Crowdsourcing, polling question number 1. And I think Katrina's going to help us with a Zoom poll on this. Oh, good. I see it pop up. So question number 1 is, what % of the eligible population would you estimate will be reached by outreach efforts? So this is sort of that first step I was talking about. You've got your eligible population, but we're going to outreach and we may not get to everybody. There may not be contact information or whatever it is, but what % do you think you'd actually be able to reach by any kind of outreach efforts? And efforts, we mean phone, email, text, whatever is available. I guess text isn't always available, but whatever's available, what % can we outreach? And I have no way of knowing if the polling's going okay. I'm assuming it is.
Yeah, we're halfway
know?
there. We're about 55%.
Okay, let's wait another minute or two, just because not everyone's probably either doesn't have an answer or isn't looking at the poll right now. Okay, Katrina, how are we doing?
We have slowed down, so I'm going to end the poll.
Okay, great. Okay. And are we able to see the results of it? Oh, great.
Oh, this
Awesome.
is so much higher than I would have guessed. I would have
Yeah,
guessed
same.
percent, maybe 10 to 25, but no way would I have guessed that we would actually engage with up to 50% of the eligible population.
Yeah, this is actually really good news. Okay. Any comments? And if anyone has thoughts in the chat, like are there key drivers to and key factors that would result in outreach? What have you seen be successful in terms of outreach, or the most successful in terms of outreach?
And just want to add that Elaine had a question about population. So the population would be the eligible population. So if your state has a FIM program for perinatal, high-risk perinatal populations, the eligible population would be just people who are in that category, who have gestational diabetes or whatever the criteria is. And if maybe the state also has a food insecurity plus gestational diabetes or whatever the criteria is, so that would be the eligible population. And we're going to ask later questions about whether or not they accepted the service and got the service. This is just about like, were they able to be offered the service? Like, what did a
Could we
human
even, yeah,
talk to them? Yeah.
could we
Yeah.
even reach out to them?
Sandra.
Hi, so I'm with the CBO. We do medically tailored meals with the health plans. I answered 25 to 50%. I know that's kind of like a combination in our experience of clients that are referred from the health plan, who a combination of people of loss to follow-up people and people who like maybe aren't eligible because they're outside of our service area or things like that. But that's why I answered that way. I would say 25 to 50, about 50% probably is what we can do now, or what we are doing now. It depends greatly on how good the referral is and if it's and how warm the referral is. So that's my input.
Yeah, is that numbers, are most of those warm referrals, like someone asked them, do you want a medically tailored food provider to reach out to you? Or most of these just like lists of people?
We do not have lists of people right now. I've done lists of people before with different populations, and that is much harder. But also it was not for medically tailored meals, it was for the like case management support. So it's very different when you're offering people free food. So I don't know.
Yeah. Great. Well, let's keep moving just to get through, because we have several questions and we want to crowdsource all our questions because we're just using this for our own purposes, getting as much data as we can from all of you. I saw there was a comment thinking that I actually knew the answer and I don't. So I think obviously that it's an actuary answer. It depends, but it's true. It does just depend on lots of factors. So question 2, of the % that you actually outreach to, what % are going to enroll? Like, so how many are actually going to accept the food and say, I really want this? And while we're waiting, this time I'll cue just, please throw any other comments or thoughts about this particular question in the chat. How do you get people to want to accept the benefit, or what causes them not to accept it? Any thoughts on that? And by the way, it's okay to answer these if you don't really know the answer. If you have a guess, that's fine too, but we'd love to hear both. But any experience you've had with outreach or enrollment or engagement of members in programs like this. Thanks for these. I'm reading through the comments as they come in. Thanks. And Katrina, how are we doing on the poll?
We're at 52%. They're slowly coming in.
Okay. %90 of members is amazing. So that is under the first version of the Massachusetts 1115. Wow.
And I think where it came from, care management and community health workers who were setting expectations with those members and assuring the right phone numbers,
Okay.
had a lot to do with that.
Great. Okay. Well, thanks. Okay, so this is interesting. I guess I would have expected to maybe skew a little higher. I don't know, Catherine, how you thought, but we're talking about the greatest number in the 25 to 50% range of those who actually accept the program, accept the benefit. And then the vast majority are, over 25%. Cool, thank you. Okay, let's go to question 3, just in the interest of time. For this one, what % of the eligible population will actually receive services when you're at full capacity? So once you've ramped up, once you've got everyone outreached and everybody of your starting population, this is sort of like that check your work number. How many are actually going to, in total, receive the benefit?
And you can change your answer from what you said the last two.
Yeah, if you said something the last two and it doesn't multiply, that's
Yeah.
okay. We're not going to check the math up.
Of 100 eligible people, how many actually got enrolled? And the reason we're diving into these is this is one place where we see wildly different numbers state by state, and it does impact states' willingness to participate, MCO's willingness to participate. And so that's why we're just like gathering a little bit of additional data.
And there's a great comment. Acceptance might also depend on the specific groceries provided and what % of the potential participants cook or have the resources to cook or have the time to cook. Such a good point. And I would also add to that potentially also cultural relevance of the food and cultural background. Okay. Any other comments on sort of that overall population? Okay, we've got, oh, good, 25 to 50. Overall will receive the benefit. I think that's kind of where we were headed with it too, Catherine. So that's sort of validating.
That's a nice validation. It's a little
Yeah.
higher maybe than I had been thinking, but it's in the right ballpark.
Yeah, great. Thanks all. Okay, let's go to question 4. This is that ramp up concept. So now backing up another step, just to say we've outreached, someone's accepted the benefit, but we can't enroll everybody on the first day, and it'll take us a while to make all those calls, to get everyone enrolled, to get them up and running. What do you think is the ramp up time, like in total, that it takes till you reach the number of people, that kind of that optimal or maximum number of people? And if you have specific experience about this, we'd love to hear it in the chat, or just any comments about ramp up and how, like what drives that? Like for example, I think probably staffing is a big driver of that, but also I'm sure there are other drivers as well.
Can I ask a clarifying question on this?
Of course.
Are you asking about how many months would it take until we reach a number of people we anticipate or hope to reach? Just outreach solely, or to be at the capacity to meet the need?
The latter, I would say. Kind of that ultimate, this is sort of that ultimate, how long do you think it takes just to get everyone who might ever become enrolled, get them enrolled into the program?
Okay, so not so much of when can we actually have all the resources ready to deploy to them once we have them signed.
I think consider that as well. Actually, I didn't understand what you meant. So yeah. And of course, that's going to depend on the resources you have at the beginning of the program. But just want to hear anyone's experience or anyone's thoughts on this. Okay, are we pretty well through the, oh, there we go. Oh gosh, okay. The big, pretty evenly distributed in all of the buckets, which is really, really interesting to me. At least no one's beyond 36 months. That's good. But a few are at, 2 years plus, which is very, very interesting. Any final chat comments on this? This is fascinating to me. Okay, let's move on to question 5. On average, how long do people participate in medically tailored grocery programs? And I know we're specific to MTGs, but answer in the best way you can if you haven't used those. And again, I would love to hear comments on why people don't continue, or whether these timeframes that are typically allotted for in the state programs, if they're long enough. Any comments you have about how long these programs are utilized? Until the programs run out of money. Yep, that's fair. I'm reading through some of these comments. Oh, Liz, interesting about the WIC program, where they said they were fully enrolled because they'd made an assumption that 80% would enroll. So they made it to 80, and so they were doing a great job. That's fascinating. Okay, how are we doing on the poll? Okay, 6 months and 7 to 12 months are the biggest answers here. Great. And that kind of aligns with what we were thinking too. Let's go on to the next one. Okay, what is the ideal duration of a program? And that kind of goes along with the last comment in the chat, which is was it 6 months, because that's typically what the limit is in many states. I'm sure that has a lot to do with it. I think good comment. It depends on the aim of the treatment for sure. Hmm. How's the poll? Can we go ahead and let's go ahead and look at the results. Ideal duration is, okay, 10 to 12 months is a pretty strong answer. Some 4 to 6 months, and then some even longer, which is interesting. Great. Okay, let's go ahead to
Yeah, we should probably.
I know. So let's see. I think, well, this is the last slide. So let's just quickly answer this one. What % of weekly dietary needs should a medically tailored grocery program meet? Hopefully this is a quick one. Okay, let's go ahead and look at the results of this one.
Just a second, they are coming in quickly.
Oh, okay, gotcha.
All right.
Great. Okay, so 33 to 67. A few said more than 67%, so more than 2 out of 3 meals a day. Most are in that 1 to 2 meals a day. Great. Okay, so I think actually, Jillian, go ahead to the next slide. I think that's the last slide. Yep. We're not going to walk through the model here, but I'm happy to in the breakouts if we have time. But what will be provided in the paper is, let's go ahead and flip to the next slide. Next step. So we're hoping to get that out next month, and then it'll be open for feedback and comments, and then we'll release a final paper in January. And with the paper will be an Excel-based model that can be used to help you do those calculations. And we're hoping to make both those available in December. So I think that's all I have for today, but I think we can move into the breakout sessions, and I'll turn it back over to Catherine and Julian.
Yeah, thank you so much, Sarah, and thank you to Amanda and Kim for great talks. And thank you also for all of our special guest stars between
Yes.
Sam and Maria and Gary. You all added a lot of great insights. In our last bit of time, so this whole meeting ends at 4, so we'll probably take about 10 to 12 minutes in the breakout rooms, which will function as spaces where you can have Q&A with each of the speakers. Everybody, this is the end of the meeting. It's been an hour and a half, even though there's so much great information packed in. And agree, Catherine, I feel like we all need more time with each other. But we should all send you all on your way, because I'm sure everyone has a 4 o'clock meeting or 1 o'clock or 2 o'clock, wherever you are in the country. Thank you again so much for being here, and we appreciate all the feedback and information and learning that you've given to us. And please have a great Thanksgiving. I hope everybody eats some great food, stays warm and safe and dry, and gets to spend some good time with your loved ones. Thank you so much.